So the talk is really about fixation principles in osteoporotic fractures. We're all facing the elderly population, and it's an ongoing program, and it's nice to know what's the problem, how to improve the chances of the patient fixation to lead to good outcomes. So I have no financial disclosures, just affiliations with both societies. But what's the problem? It's when we see these x-rays, these very osteoporotic patients with severe osteoporosis, the bone is very thinned out. It's then that you worry about your fixation and how you're going to deal with these patients. And when you go inside, you can see on the picture on the right, the very thinned out cortex, the eggshell thinned out cortex. But are we seeing osteoporosis only in these elderly patients? It's not only the 95-year-old patient that we're seeing it in. You can see severe osteoporosis in a 40-year-old which has another pathology. So like this patient that had a chronic renal failure and was on regular dialysis, and it's the same as the elderly patient. So you'd be treating her on the same principles. So it's not only the elderly, but sometimes renal failure, hyperparathyroidism, which is unrecognized and untreated, and sometimes we see these patients and we discover the hyperparathyroidism when the patient comes with the fracture. So you have to realize, if it's not in the elderly, you have to be thinking of what's the cause of this severe osteoporosis, and of course chronic steroid therapy. So when you're thinking of managing osteoporotic fractures, I don't want you just to think about the fracture. I want you to think outside the bone. As you will see with the elderly, there's a lot of physical and mental challenges that we have to deal with that will be covered in the next few talks. But it's the renal failure, the hyperparathyroidism, and the steroid. You also have to be thinking about the patient and the general management of the patient, not only the fracture itself. So in this talk, we want to cover the structural changes that happen in osteoporosis for the bone, what implants that we can use for these fractures, and the fixation principle of using these implants. Now, the WHO described osteoporosis as a low bone BMD, and at the same time, there's a lot of architectural deterioration. So it's less of quantity of the bone, but also the quality is not as good. There's an increase in the haversian canals, and that leads to weaker bone, and then you get the low energy fractures. For the cortical bone itself, we get thinning of the cortex, and thus you get wider. The bone tries to compensate to carry the load by getting wider because the cortex is weaker and thinner. And when you have this eggshell cortex, we've all had the screws that you try to tighten osteoporotic bone but never got that hold. So you get a less working left from the screw, and then it's a weak fixation. And tests were done to compare the load to failure between the regular 4.5 cortical screw with the unicortical locked screw versus the bicortical 4 and 5 millimeter lock screws. And as you can see, it's only the bicortical screws that have almost double the load to failure than the regular 4.5 screws. So the unicortical, although they were in vogue for a while, they're not being used anymore because they're not much stronger than the 4.5 screws. So these are the ones that are being used mostly now. And this is a case of an elderly patient with a comminuted distal femoral fracture, and then was treated with a list plate but only unicortical lock screws. But unfortunately, just soon after the operation, this failed and had to be converted into bicortical lock screws. But we also have changes in the cancellous bone. We have less trabeculae, they are thinner, and the interconnections in between are weaker and may be broken. And you can see on the pictures comparative spine of a young patient versus an osteoporotic patient. And this is a CT to show you changes in both the cortical and the cancellous bone in an elderly specimen of both. They're both elderly, but one has osteoporosis on the right. You can see the cortex that's thinned out. You can see the less trabeculae of the cancellous bone versus the one on the left. So what does that lead to? How does that affect us? When you don't have the cortical strength and you don't have anything inside the bone to resist it, then the implant has nothing to be resistant to cut out. So you have more cut out and you have voids after a fracture. We've seen that with osteoporotic bone, you go in and there's empty space, such as sometimes you see with calcaneal fractures. So the main message here is that it's a bone failure rather than an implant failure. We rarely see implant failure with osteoporotic fracture. It's usually what we're concerned of, that the metal will come out of the bone. So how do you look for these? As you just heard, obviously you can do a DEXA scan, but that's not always available. But there are signs that these patients must be suffering from osteoporosis. Besides what the X-ray might look like, you have the multiple vertebral fractures, previous history of hip, plateau fractures, and the patients which are on renal failure or chronic steroid use. So what are the problems that we are facing when we want to fix osteoporotic fractures? So we have the less bone mass, therefore your screws are not holding as well. You commonly see comminution, and you have to deal with that, and possibly altered healing potential for the fracture. And these all lead to failure through screw pullout or implant cutout. So what's the solution? How can we try to improve that? Locked implants with angular stability are the main advancement to deal with these fractures. But we also have to apply the correct fixation principles, and we should try to minimize further bone loss as soon as possible. So as you'll hear probably in the next talks, is as soon as you can, you should start using anti-resorptive drugs if the patient is already not on them. So if we take the first one, which is the locked implants, you all know about locked implants. They're available now in many countries, and we've seen how they hold better in the bone, and there's less failure of the implants, either with locked plates or with angular stable lock system in the nailing. For the fixation principles, you want to go for relative stability. You should avoid trying to get the absolute stability. So you want to get functional reduction, no lag screws, and just compression enough to have the bone ends close to each other. But don't try to compress the bone too much, because if you try to do that, it's very fragile and it will break. We always want to go for long splinting. You want to do a low distribution, get a high lever arm, moment arm to hold the bone. And when you have comminution, you may think of shortening or impaction of the comminuted area. That will give you a more stable construct and will give you a more bone mass in that area. And finally, you've just heard about augmentation and the benefits of that. So this is a case, again, of a 70-year-old female with a distal femoral fracture, and then she has a total knee replacement. So she was treated with a locked implant, splinting the fracture, away, no lag screws, and then she went on to healing with indirect bone healing and callus formation. This is another case of a midshaft fracture in an elderly patient with osteoporosis, and you can see the oblique design of the fracture, and this is very tempting to all of us to try to put a lag screw. And the surgeon tried to do that, but he got eventually comminution at the fracture site. So he just continued and bridged the fracture with a bridging plate, relative stability, and then this goes on to nice healing. But there are also implants that can help with impaction of the fracture, like the DHS, which we use commonly. So in an elderly patient, if you have slight impaction on the fracture site, that is helpful. And you can be expecting that and looking for that afterwards. But if you have comminution, like in the proximal humeral fracture, and you're planning to use a lock device, this will not allow any movement afterwards. So your impaction or shortening should be planned in the operation during the reduction. You bring the shaft up slightly into the head, shorten it, avoid the comminution, and then put your lock device. Finally, the augmentation. You've heard about the cement or the tricalcium phosphate augmentation. You should try to avoid having that in the fracture site. And that increases the material density, it helps the screw purchase, and improves the screw pull-out strength. You may have combined fractures in these elderly patients. So this one has a proximal humeral fracture and a distal humeral fracture at the same time on the same limb. So she's treated with a locked proximal humeral fracture plate and locked bicondylar plating of the distal humerus. When you have an articular fracture or an interarticular fracture, again, it's the principles. You will not be able to lag these fractures. So it's just getting this fracture aligned, in position, possibly just with a clamp to get it in place, and then you put your neutralization screw or your lock screws, which will act as your neutralization screw. So you don't need the lag screw in these fractures. And this is the outcome. So finally, another case, which is a distal humeral fracture with comminution. Think of long, locked implants, bridging the fracture, relative stability, avoid dealing with the fracture itself as much as possible, and it goes on to nice healing. So in summary, it's mostly a bone failure, not an implant failure. This is what you should keep in mind. We want always to increase the contact area between the implant and the bone. We should be targeting to work with locked implants. And for the fixation principles, you want to go for relative stability with functional reduction, long implants, and when you have comminution, you may change your principle and have metaphyseal impaction or shortening, and always think of augmentation also as a possibility. But overall, I want you to think that age and osteoporosis, they affect the bone and the patient in different ways. So don't only think about the fracture, but I also want you to think about outside the bone.